Hi, I'm Interne Francesco and I'm glad to introduce you a new lecture in digital dentistry. In this lecture I will try to give you my experience in the new approach that we have and the new tools that we have in prosto and in implant dentistry. So we are looking a little bit about the new paradigms in digital dentistry. We are focusing our attention on the treatment plan, in digital impression, in how to create the digital patient, for example, and which type of material sometimes you can use in this new approach. So what it will be really interesting in this lecture is that several times we have a problem using this kind of tool that is related to the communication that we have with the lab. In this new approach with the digital patient concept, we can share all the information that we have from the clinic to the lab, and this will give the opportunity to the lab to create the best result as possible. Okay, so but in any case, every single time we speak about digital dentistry, it comes up some question in our mind, and these questions are: is that precise? Can we take in a predictable way a nice impression? Is something that we can do routinely? It's can we place the upper cast in the right position as we were used to do in the past with the Facebook, for example? And all these questions together create the main question: is right now the time to start with digital dentistry or not, or we have to wait something? And with this presentation I will try to give you the answer. I will try to give you the answer, and then at the end we will see together what is my answer to this question. So in any case, every single time we start with a new rehabilitation, new full mouth rehabilitation, for sure we have to understand what is the circle of the thing that we have to do. So first of all, we have to understand what the patient wants. Is the patient coming only because of pain somewhere, or it's interested in to do something more? It's interested in improve aesthetic and function, for example. Then what we have to do is collect all the information. So it means that we have to, for example, make a periodontal chart. We have to take some impression. We have to take the Facebook in the beginning just to set the study model in the right way. And then, for sure, a bite registration. And then with all this information and all the data that we have, what we have to do, following the aesthetic rules, so the aesthetic idea that we must have in our mind, we create an hypothesis. An hypothesis means that we have to have the finish line in our mind before to start. So we have to know exactly what we want to do. And then we have the pre-visualization. Pre-visualization is putting our idea, our hypothesis in the mouth of the patient. So sometimes it's a mock-up, can be a digital mock-up, or in any case something that gives to the patient the right idea of the future prosthetic profile. And then in this way, the patient will have a clear idea about the final result. It's at that point that we can make an estimate of time and money for the patient, not for sure in the beginning. And then only at this time we can start with the active part of the therapy. So it means surgery, preparation, and so on to achieve the final predictable result. So for sure this hypothesis must be guided from the smile design, so digital smile design, from the digital approach in general. And but for sure we have to follow the aesthetic rules that we saw before. So remember that the digital tools that we have are tools. So if we have a great tool, but we are not expert in driving this tool in the right direction, for sure it's unuseful. It's something that we cannot use in our daily practice. So for us it's important to be expert and know exactly what we have to do. Okay? So remember that the digital tool doesn't make the work alone. Okay, you have to guide this tool to obtain a really predictable result. So every single time we start, for example, for a full mouth rehabilitation or a rehabilitation where it's important, the aesthetic and function, for sure we can approach with the traditional approach. So it means creating a radiographic guide that follow the aesthetic rules, and then we place in the mouth of the patient, and then we can take, for example, a CT. Or we can, for example, through the use of photography, we can design a perfect smile, so the digital smile design. But what I am going to present today is the digital patient concept, so something that we can put together, recording all the information that we need, and this will be something that will be perfect for the technician in the way to design some little stuff. But first of all, we have to give the right information, okay? So remember, every single time we have a new patient, if it's a dental or something, but even if the patient has the teeth, we have to consider the mouth of the patient as an empty space. An empty space, and then it's with this approach that we have to understand if the teeth are in the right position or where to place the teeth of the rehabilitation. And so the first step for sure is to locate the incisal edge of the central incisor. After we locate the incisal edge of the central incisor, we have to create with the proportion of the teeth, so between 75 to 80% between width and height, and then we locate the future free gingival margin, the ideal future free gingival margin. Then, understanding the orientation of the occlusal plane and the vertical dimension, we will be able to create the perfect smile for the patient. So only in this way, so first we have to locate the incisal edge of the central incisor, then proportion, the future free gingival margin, occlusal plane, vertical dimension, and then we can set everything. If the future free gingival margin is not there, our task is to bring the tissue there. If the bone is not there for an implant placement, we will work with the GBR. And so this is the way of thinking of the full mouth rehabilitation in aesthetic dentistry. So every single time we start a new case, for sure it's important to make an aesthetic analysis, labial dental analysis, and the facial analysis of the patient. And remember that it's only when you consider the space between the lips as an empty space and you create the ideal restoration, you will be able to finalize the case in the best way. So our treatment plan must always be facially generated. So we start from aesthetic, then function, structure, and biology in the way to create the predictable result in the patient mouth. As soon as we start to speak about digital dentistry, the digital future, for example, we can consider that we have a lot of information that can share with the other part of the team, so an orthodontist, the technician, maxillofacial surgeon. So we have a lot of information, and this is for us really interesting. And with this tool, we will see how to plan our cases. So normally, where we start from? We start from an impression, a digital impression or a traditional impression. And then if I start to analyze the differences, remember that the traditional impression has some problem as well. If you don't take a really good impression, it means with the right material and in the right way, what we have are casts that sometimes can be not perfect, so can have a lot of bubble inside the grooves. And if you have a lot of bubbles, even if it's an antagonist, for sure the technician will have trouble in sitting in a perfect way the antagonist on the master cast, and that will come out with some problem also at the biscuit tray. Why? Because we will have a lot of adjustment to do. If we have a perfect impression, we can do everything in a perfect way since the beginning. But what about the digital impression? The digital impression is more or less it's the same. We have to consider the tool that we have in our hands, so an intraoral scanner, and then we can start to read the surface of the mouth of the patient, and we will be able to take the soft tissue, the teeth, or for example we can take the scan body. So we have the intraoral impression. We will see later how in this case it's not important the material. We don't have material, we have the hardware, so the intraoral scanner for example, or the software. But what is really important sometimes is to have a protocol in the way to scan the mouth of the patient. And then when we finish, for sure we have a result that is what you can see in the screen, so it's a digital impression. But what are the most important difference? Our digital impression is already a cast. We haven't to pour the impression to obtain the cast. So we will see later also, if we speak about timing, that the digital path will be much faster than the traditional one. And then as soon as we start to evaluate a little bit the literature, we understand that sometimes it's not clear. There are beautiful articles that try to explain a little better digital versus conventional full arch impression, and it seems in some article that the digital impression is much more precise than traditional one. In other articles, we have exactly the opposite. This is a really nice article in an in vivo study that where they put 4 little balls in the arches, and then they scan the position, and with this holder that were giving the trueness of the position of this little ball, we have the opportunity to assess what is the precision of the digital impression. And in this study, it seems that the conventional impression is still better. So it's not easy to understand where is the true, where we have to go. But in any case, we will see probably that there are opportunity to assess this and to adjust if we have a little problem in precision sometime. If we speak about the time efficiency of the intraoral scanner, for sure, if we consider starting from the abutment to the fabrication, so it means the time that we take the impression, we pour the impression, and that the technician is ready to create the rehabilitation. With the conventional, we have a lot of steps. Some steps are not present in the digital path, and so for this reason, it becomes faster. If you see this article, it's interesting to see that they have 3 different scenarios. One was the single crown, one was the little bridge, and the other one was the full arch. But if we compare the time for single crown, for example, we have 5 minutes 57 seconds against at least 18 minutes of the conventional. So you can see that sometimes it's much faster. And without speak about the process of creating the prosthesis, so in the lab. This is for us really interesting to understand. As I was telling you, for us also interesting is to analyzing what are the way in which we can take a better impression, and so the scanning protocols. We cannot jump inside the mouth and dance like crazy, because otherwise the precision of the impression is not ideal. So we have a precise protocol in the way to obtain a predictable impression, okay? But it's the same, exactly the same, if you have to take an impression in the traditional way. If you start to move, for example, the impression material during the setting time, for sure we will not have a precise impression. So there is rules for every single material or tools that we use. But look at this analysis that we try to do. I try to get in the mouth with different scanning protocols, and changing the scanning protocols, we have differences that sometimes are really huge. So for us, if we want to be predictable in digital dentistry, we have to follow a precise scanning protocol, and in this way we will obtain a really predictable result in precision of the impression. For sure, it's interesting, this article that describes that the individual ability to follow a specific scanning protocol affect the accuracy. It's just this. Okay, so for us it's important to understand this concept before to start. After the impression, the second step several times is the bite registration. So there are so many ways to take the bite registration in traditional path. But for sure, as soon as we try to understand if the traditional path is the reference point, we understand that, for example, if you use hard material, several times the technician has some trouble related to the opportunity to see perfectly the cast on the bite registration. Why? Because sometimes we have little bubbles, or in any case the hard material that we use for the bite registration doesn't fit exactly in the grooves of the cast. And so the technician has to work a lot, and sometimes result in little differences. So for us it's important to see that also the traditional path can have some trouble, some problem, okay? And for this reason, right now, I want to show you the traditional way in which I take the bite registration, especially if there is to increase the vertical dimension. So first of all, we have to understand that if we are speaking of a full mouth rehabilitation, in my opinion, there is the need to understand that normally the best way to go is to work in CR position if the patient have the opportunity to go in a CR position without pain. And then for sure another important stuff is that we have to consider, never change the vertical dimension inside the articulator if it's possible. So you have to take the bite registration in CR position at the right vertical dimension. And with this procedure, with the use of this plastic foil, in the way to avoid that the hard material of the bite registration can go in the grooves, we can use an anterior deprogrammer already set at the right vertical dimension. Then we can ask the patient to move forward, backward, and then we can record the position through the occlusal paper. At the end, when we are sure of the position, we can inject some material between the arches, and this is the right position, or better, the CR position at the right vertical dimension. And so for us, it's the starting point. So right now, it's important to understand that if we push the mandible, we don't go in the right position, or it's also important to understand that every single time we want to have a predictable position, we have to work in CR for the full mouth rehabilitation. And what about digital? There is any differences? Okay, as soon as we start to analyze the digital path, and we have to take a bite registration, the concepts are exactly the same. We have to bring the patient in CR position. Okay, so the patient must be in CR position exactly as before. It changes only the way in which we take the bite registration. We don't need material. We don't need plastic foil. We don't need anything. We only need the anterior deprogrammer. We ask the patient move forward, backward as before. We put the position of the mandible right as it was before, and then instead to put the material, what we have to do, we have to scan the arches in the way that the software can record the position of the teeth, and it will bring exactly the arches in the position that we put. So for us it's important to understand that the concept in the back are exactly the same, nothing changed, and for us it's a different way to obtain the same result. Why it's better to have a digital impression and recording the bite in this way? Because in this way, as you can see here, we can show to the patient what are the problems. Whereas, for example, abrasion, erosion, or why, for example, in a case like this, we have to wear ortho in the way to bring the teeth in the right position. Or we can see details. And remember, for the case acceptance, if you are really clear in your explanation, probably you will be much more successful. So for us, this is also a really interesting tool. Then what we miss? We miss, for example, the Facebook. So if we want to locate the upper arch in the traditional path in the right position according to the horizon, what we have to do is to take the Facebook. We have to know that the Facebook, the horizontal branch, must be parallel to the horizon that we decided for the patient, and then it's a couple of minutes, and then with this device we are able to transfer the position of the upper arch inside the articulator, and the technician will have an idea about how it's positioned at the upper cast in the space. And this is, for me, it's the base for a full mouth rehabilitation. But it's the only thing that we have to do, or do you think that there is something more in the way to organize the orientation of the occlusal plane in the space? Remember that after the technician has this position of the cast in the articulator, if they are not organizing their walks up or the mounting of the teeth in the right position, doesn't matter the Facebook. So for example, look at here, in relationship of different type of Facebook, we have different orientation in the space of the occlusal plane. As you can see, if it's Frankfurt oriented, we have a position. If it's camper oriented or a modified camper oriented position, we have another position. And you can see that the inclination of the cast inside the articulator are different. There are at least 5 degrees. Okay, and important for us, if we want to be predictable in the traditional path, we have to use adjustable occlusal plane. Adjustable occlusal plane that the technician have to mount inside the articulator, considering the skeletal class, create the ideal inclination of the occlusal plane. I don't know, for example, 8 degrees for a class 1, 12 degrees for a class 2, or more flat like 5 degrees for a class 3, okay? And in this case, the occlusal plane will be oriented accordingly to the horizon, but with the right inclination. Okay, this is important. If we give only the Facebook to the technician, but we don't give any input to use this kind of tool, for example, our occlusal plane will not be well oriented. So right now I'm going to show you in difference what we can do with the in digital dentistry. According to the concept of the natural head position, we can place the patient in front of a mirror and start to record or to scanning the face. So we want to have like a patient as it was in the reality, so a patient that we can rotate inside the screen and see whatever, okay? And so, as you can see here, we are right now scanning the face of the patient. Right now we are using the most important key factor, that is the scan fork. The scan fork is a device that after it's scanned, give you the opportunity to locate the upper cast according to the position of the face. And as you can see, after this step, you can start to match the different scanning of the face, and you will have a digital patient that is in front of you. So right now what we have to do, after we have the digital patient, we have to start to locate the upper cast, as you can see here, in the space or in the face of the patient. And it's just with the use of the scan fork that we can do that. And as you can see here, right now for me it's easy to understand where the teeth are. We can speak in the team how much we have to increase the length of this central incisor. And remember that you have the opportunity to have the patient in rest position. You have the opportunity to have the patient with the smile. And then if you change in transparency, for example, the skin, you can see the underlying bone. And look at here, after that, it's not a game. We can start to work to create the ideal restoration. And so we can start digital modeling the rehabilitation. And it's easy because the technician has also the occlusal plane, has the midline, and the orientation of the occlusal plane will be done with the horizon and according to the ala tragus line. So it will be really easy for us to orient it, to create an ideal orientation of the occlusal plane. When we are at the end of our modeling process, more or less happy about what we obtain looking the face of the patient, what we can do also, we can go inside the cross-section, and so you can remove, for example, the soft tissue completely, then you go inside the cross-section and you can see where is the bone according to the profile of the prosthesis you create. And so for us it's interesting because we can, for example, assess how much bone we have to remove if we do a crown lengthening procedure. Or, for example, if we are overlapping too much, and then we can create some kind of recession with our prosthesis, or where to place the implant according to the final position of the prosthesis. So every single step can be done in a really predictable way. So our way of thinking changed completely in this kind of approach. Everything can be evaluated before. So getting back to the concept that we saw before, so considering the mouth of the patient as an empty space, when we have to plan with this kind of tools, what we can do is starting from the empty mouth and then start to design our horizon, the midline, and all the other stuff, create the occlusal plane orientation. And as you can see in this picture, it's so easy to create the perfect prosthetic profile. And then we have inside all the anatomy. All this anatomy are going to create the STL file that we will use in the way to mill the pre-visualization, what we call the snap-on mock-up. So something that will fit inside the mouth and will give us the opportunity to check the new aesthetic, the function and everything, the new vertical dimension and so on. And so look at here, this is what we can do. So we can mill with the PMMA something that can overlap our dentition without any kind of preparation, and then we can understand the new aesthetic. Remember that in cases like this we can mill easily till 0.1, so really thin. And you can see that right now with this kind of snap-on mock-up, in 2 seconds we can fix in the mouth, as you can see here. And after fixing, we can understand immediately if we are in the right direction. And it's easy for us later on transform, for example, this kind of snap-on mock-up in a provisional restoration. And we can use as a splint in the way to test the new vertical dimension, for example. And with this, we can immediately understand if our idea of aesthetic is what the patient wants. So if the idea is that we have in our mind, it's something that in some way it's in the desire of the patient. So if everything is fine, so we can step forward and analyze a little bit the case and then start the second part of the case, so the surgery or implant placement or so ever. Remember that we can have a digital articulator, so also from a functional point of view, our mock-up or our rehabilitation in digital dentistry can be perfect as we do normally in the traditional path. And for sure, we have so many evaluations that we can do. We can see the proportion, we can see the anatomy, and then for sure it's interesting, for example, changing in transparency the different object. We can see where is the shape of the final restoration comparing what we have in the mouth. And so we can understand, for example, how much tissue we have to remove, if there is enough keratinized tissue for a crown lengthening, or if we have to do an apical repositioning flap, and much more. This information can go directly to the orthodontist in the way to understand what we want. And you see that in this case, with this STL file, the orthodontist can move exactly the teeth according to our treatment plan. So it's something that is really useful and something that is not possible with the traditional way to go. Another important topic, it's for example crown lengthening. In this case I know exactly, for example, the future free gingival margin, and I know from the beginning how much bone I have to remove. And we know that if we go inside with an internal bevel, because the bone is far away, the healing process will take 1 month. But as soon as we open the flap and we remove some bone from the buccal side, the healing period becomes 3 months. And if we open everything, because we see that there is too much bone to remove, and so we have also to open the palatal flap, probably we need more, 6 months in the way to have stable tissue. So you can immediately assess before to start what is the target, and then you can make an estimate of time and money for the patient. That's something that is really important. Then another important evaluation that we can do during the orthodontic treatment, for example, we can take digital impression and then we can overimpose this digital impression with the project that we have. And we will know exactly if we are in the right direction, if we have to do more, or if we already achieve the target. So right now what I want to show you, it's a case, step-by-step digital case of a single central incisor from A to Z, in the way to explain you a little better what we can do. We spoke about digital patient, and I told you that the digital patient is needed especially for the full mouth rehabilitation. As soon as we speak about single tooth, the digital patient is not needed. Why? Because we are going to copy exactly the neighboring one and the contralateral tooth, for example, in the way to obtain a perfect result if everything is fine. And so we see this patient that come in my office because she has some pain in the central incisor, looking the picture and going in a systematic approach as we do normally in the traditional approach. We can see that everything seems fine and the aesthetic is fine. And the only thing that we can see here, we can assess here, for example, is that the number 8 has a little short crown compared to the other, but seems nothing really important, something that can, okay, leave like it is without problem. But as soon as we look from the palatal side, we can assess that there is a dark area and a shadow that probably it's not ideal. And as soon as we take a probe, in cases like this we can see, or for example in this case, that the probe, periodontal probe, fall in. So this is several times, it's the signal of an external resorption of the root. So immediately in these cases, what we have to do is we have to start to take the CBT, for example, to analyze a little better the case. And in this specific case, what we saw that there was an internal resorption quite important, really big, till the pulp. And was this the reason? Because the patient has pain, okay? And so we know that from the literature that this is related to the presence of osteoclast that can resorb the root. And if it's in the beginning, this process, probably we can save the tooth repairing the root with MTA. But if it's too much, probably the only way to go is to extract the tooth. And so in all these cases, we are in a central incisor, quite young female. It's always difficult for me to place implant because we have to take care of so many things. And especially in smile, so beautiful mouth, for example. But important is to remember that every single time we extract a tooth, we have some kind of resorption, some kind of alteration. There is no way to go. As soon as we remove the root and we remove the periodontal fiber, we have also we lose the bundle bone, and so we have some kind of remodeling of that area. And it's interesting to see from this article from the German group that even if we place material, xenograph, we place connective tissue, there is no way to maintain exactly the same volume. We have always some type of alteration of the crest. So is this the reason? Because right now I want to show you a different approach. I have already presented this kind of approach in the past presentation, so it's the socket shield technique. Right now, after evaluating the case, I start with my digital approach, so evaluating the situation that I have with the software, the software that I normally use to plan my surgery. And as you can see here, right now I'm planning to place the implant accordingly to the idea to keep a shield in the front. Okay, so I'm placing the implant according to the bone level. So we see that the bone level is more or less 3 millimeters below the future free gingival margin. And after I plan my implant in details of the position, I can create my surgical guide. Remember that the surgical guide is not only useful in the way to place the implant, but it's also useful because we can create in a predictable way a provisional restoration. So for us it's really important to have something like this before to start. So as you can see here, as soon as I finish my planning, I have here my surgical guide that is created in the way to guide my osteotomy and in the way to place the implant and also to create my provisional restoration. So this is the surgical guide that we have. If we are in condition like this where we can go with an intraoral scanner, take an impression, for sure the surgical guide will sit more precisely comparing what we can obtain if we use only the CT of the patient. Here, for example, you see the clinical approach. So right now I have my tooth, I have to remove the tooth, but to remove the tooth, leaving the buccal shield, what we have to do normally is to cut the horizontal way the crown of the tooth. Normally I use this type of bar that are normally the bar that we use for the wisdom tooth and so on. And after we cut in a horizontal way the root, we can see much better what is going on. And then it's important in the way to leave in a predictable way the shield that we want to have to cut till the apex. Remember that we have to remove the apex. In the socket shield technique, we have to remove the apex, especially if we are in rooted treated tooth. Okay? But in any case, as you can see here, you saw the invagination of the tissue inside the root. And then right now, after we remove the upper part of the parietal part of the root, we also remove the apex. After we remove everything, we start to decrease the height of the shield in the front. That will be not at the bone level, but we have to keep this shield 1 millimeter above, in the way to leave the horizontal fibers inserted in the root as they are in the way to maintain the anatomy and the scallop design of the tissue. Okay, after we decrease the height of our shield, we can start with the guided surgery. So we place in the mouth our guide, and we start step by step the osteotomy. What is important to understand in these cases, especially if we are considering prominent root, is to avoid to underprepare. What it means to avoid to underprepare? If we underprepare, the risk is when you place, when you screw in the implant, that this pressure can push out the shield and can create damage. You can have problem. In difference, we are going to find the stability of the implant with an implant that should be longer than the previous root. Normally we consider 3 millimeters longer of the previous root. Then what we do, as was described in the article of Urzler and Sur, is the use of a melogenin that we put inside. And then also the implant placement will be done through the guide in the way to be really precise. Remember that right now we have bone level, we have the shield that is 1 millimeter above, but the implant have to go at the bone level, so will be deeper than the shield at the bone level. Okay, and then another aspect that is really important, the inner part of the sharp angle must be smoothed completely in the way to avoid any contact between the future provisional abutment and the shield. Okay, as you can see here, I created also a provisional restoration that normally I fix in the mouth through the use of flowable composite, exactly in the position that I want, and after it's fixed or the flowable composite set, it's removed from the mouth and refined outside. It's interesting to see this article. I already showed this article in a previous lecture, always about socket shield technique. What is interesting to remember that the buccal fragment must be 1 millimeter above, as I told you, in the way to maintain the horizontal fibers. Then it's interesting that the retaining the buccal bone aspect of the root doesn't appear to interfere with the osseointegration. This is the most important message that we have to give. Then, for sure, we are at this phase. We are after 3 months of the implant placement. You can see the provisional restoration. It's a nice provisional restoration. And then what we have to do if we want to continue in the digital path is just to copy what we have. And just to copy what we have to start to take a digital impression. So we take a digital impression of the provisional restoration, and after we take this digital impression of the provisional restoration that will be like the prototype of our final restoration, we can take it out, take the provisional out. Remember that every single time you remove a provisional restoration on implant, you have the soft tissues that are going to collapse immediately. So is this the reason? Because also years ago we were used to customize the pickup impression copy in the way to give the opportunity to the technician to copy exactly the soft tissue profile that was created with the provisional. And then second, we are going to take another impression. The second impression is with the scan body, a scan body that gives through the geometry of the scan body the position of the implant. So in the virtual cast, we will have also a perfect position of the implant through the use of this scan body. What we can say about the scan body, different material. I normally prefer the titanium scan body instead to use the PEEK one, because the PEEK one are more translucent and sometimes are difficult to read. Then we have the 2 casts after this digital impression, but as you can see here, right now we have the soft tissue that is collapsed in. So we have the position of the implant, we have all the arch, we have the antagonist, but the tissue is not perfect in position as we want. So what we have to do, we have to take an impression, a digital impression, to our provisional restoration, rotating the lab analog in front of the scanner, and as you can see here, you read the surface and you will obtain the profile of the provisional restoration. As you can see here, it's more or less what we were doing years ago with the customized pickup impression copy. Right now, what you have is right now the tooth, so the soft tissue profile must be in some way controlled by the prosthesis. So in this case, you have the profile that created this kind of soft tissue line. And it's for us really important to copy this profile in our final rehabilitation. So right now we have an STL file that gives us this precise idea of the future profile inside the tissue. And then it's easy for us, we have all the information, and then we can start with the digital path, choosing the right material to create a final restoration that in some way it's ideal, it's mimetic and cannot detected as a crown or as an implant. And as you can see here, this is the final restoration that we were able to obtain. As you can see here, the distal zenith of the central incisor is more or less similar to the contralateral one. The transparency and the translucency of this restoration, even if it's completely digital, it's really mimetic. It's something that is not so easy to detect. And I think that this kind of approach of the socket shield technique demonstrates how was possible to maintain a really good volume in the buccal side. And as you can see here, this is the final result with the implant in position. And I hope that you understood a little bit about this digital approach, what is the digital patient that we normally use for full mouth rehabilitation or big cases, or the digital path for simple cases, or not simple, but cases where we don't need to have the digital patient. Okay, so if we have to draw some conclusion, I will say the precision of the digital impression is similar to the traditional for sure. Sometime we will see, probably in a future lecture, how we can be really passive with our framework if we stay in arches, so a full mouth rehabilitation with an arch on implant, for example. Then what we have to say is more or less it's better to evaluate our cases so we can analyze in details where is the bone, where is the lip in rest position, where is the ideal orientation of the occlusal plane. So there are so many evaluations that we can do with this kind of digital approach. For sure, we have a team approach because we can share the information in a better way also with the lab. And for sure, we can control the different steps. For example, in orthodontics, if we are going to take an impression in the beginning and see where we are moving, in which direction, we can see exactly where we got the target, when we get the target, and when we are ready, for example, to go for the final part of our rehabilitation, if it's a prosthetic rehabilitation. And for sure, when we speak about material, we can have material that are in some way good material. It's not something that is created by the technician that sometimes can have some problem. So every single time we involve the human being, we can have more error. But in any case, I hope you enjoy this type of presentation. Also, time saving is another issue, for example, for sure. And I hope that the answer that was clear in my mind is also for you right now. So it's the time to start with the digital dentistry. I hope you enjoyed the lecture, and I want to greeting you and see you soon. Thank you. Bye.